to order. My name is Kevin Cahill. I am the chair of the Assembly Committee on Insurance, and with me today is the ranking minority member of that committee, Will Barkley. We will be joined by Chairman Dick Gottfried of the Assembly Health Committee shortly. He is in transit. We knew that we were going to have this little bit of a delay when Dick went to see his constituents and now had to be subject to the whims of mass transit getting us back here. So he's on his way. We'll be here shortly. We welcome you to this hearing on the legislative role of modernizing health insurance coverages in New York State under the Affordable Care Act. This hearing was previously scheduled for December 17, 2015 in association with the 2015-16 budget and was rescheduled to today for the convenience of our witnesses. Our purpose is to determine and delineate the process by which the New York legislature may require new health insurance coverage, new beneficial medicines and treatments under the national health care structure. As I indicated, joining me here now is Assemblyman Will Barkley. We expect other colleagues to be joining us shortly. I'd like to thank Will and the others who will be here later for joining us for this hearing, which affects the health care of millions of New Yorkers. The Affordable Care Act requires essential health benefits which all qualified health plans must provide. Those benefits are determined by the adoption of a benchmark plan, thus defining the minimum benefit requirement. It also defines the maximum mandated requirement. And while states may require additional benefits, if a state does require that a qualified health plan offer benefits in addition to the essential health benefits plan, the state shall assume those costs. How states are to determine this cost, and that's federal law. How states are to determine this cost and upon what factors the cost shall be based have not been specified in the federal legislation. As a result, to the best of my knowledge, states have simply not enacted new benefits. In essence, health treatments and practices have been frozen at the level that technology and protocols that were in the benchmark plan selected in 2012 existed, despite ongoing advances in health care. The legislature must have the ability to require new health coverages, and to do that, the process by which the state shall determine the cost and make payments to individuals to defray that cost must be understood. In 2012, New York State chose the Oxford EPO, the state's largest small group plan, as the benchmark. On July 1st, New York State again apparently selected the Oxford EPO plan as the benchmark plan for 2017. Changes between 2012 and 2017 include the clarification of requirements for certain habilitative services through definitional updates, but we are not aware of any enhancements made to the benchmark plan which would require coverage of additional health benefits. The purpose of this hearing, then, is to outline the process for determining the premium and tax impacts of new mandates. How is the legislature to do this? Until we determine this cost estimate process, New York policyholders appear to be largely stuck at the technological health care level that existed in 2012. Though I want to develop a thorough understanding of every aspect of these issues, I ask that our witnesses limit their opening statements to no more than 10 minutes. Please feel free to summarize any written testimony that you came here with. And also, we would welcome written testimony, and we'll consider it in lieu of oral testimony, and we'll consider it as fully as we would take oral statements. The written testimony will be preserved in the public record and read by the committee members and staff along with the transcript of the oral testimony, each of whom may follow up with the witnesses for further questions. We have three sets of witnesses today. Two will be panels and one will be an individual. And we will open our hearing shortly with the first panel being Donna Frescatore, the Executive Director of New York State of Health, and Troy Oshner, the Deputy Superintendent for Health in New York State Department of Financial Services. Before we do that, I'd like to ask Will if he has any opening remarks.
I don't, Mr. Chairman.
And that's kind of what I figured, so at this point, if Ms. Frescatore and Mr. Oshner could please come down and be prepared. Thank you.
Thanks. we on? Okay.
I think you're on. Thank you for attending. What I'd like to do, if you don't mind, is give you each an opportunity for a brief opening statement on the subject that we're here to talk about, and then Will and I, and perhaps at that point maybe Dick will also be joining us for some questions. I usually wait till the end, but since Dick is not here yet and we might as well kill a couple more seconds, I would ask now that if we have additional questions and we send them to you in writing, would you be kind enough to respond to us completely, accurately, and quickly so that we can complete the record as best we can?
Absolutely,
Yes, we certainly will.
Thank you so much. With that, which one of you would like to go? Who won the coin toss?
Yeah, I'll go first.
Okay, so
and,
Troy from the
and then
Department of
Donna,
Financial Services.
Donna will jump in. So, first of all, thank you so much, Chairperson
Troy, if you
Cahill.
can move closer to the mic or...
Okay. Is that better?
Oh, way better.
Way better. Okay. First of all, thank you so very much for inviting us and giving us the opportunity. We really appreciate the chance to come before the committee on this important issue. I did want to first say, before I begin, that Acting Superintendent Maria Vullo asked me to pass along that she really looks forward to meeting you and working with you on issues of importance. So what we're going to do today is provide an overview of federal law and regulations related to state-mandated new benefits under the Affordable Care Act. And we're also going to summarize some of the new regulations recently implemented by the Department of Health and Human Services. And so we start from the ACA and the fundamental point that as of January 1st, 2014, everybody is required to have, there was a comprehensive health insurance plans must include essential health benefits. So what are the essential health benefits? And Donna's going to talk in more detail about the process for how we got there and how we got to the plan that we chose. But I will say initially that the fundamental idea was that everybody was going to have essential health, a basic set of comprehensive coverage. The ACA delegated that to HHS to figure out, and I think we all as regulators and many advocates thought that the Department of Health and Human Services was going to set one standard across the country, and that's not what they ended up doing. What they ended up doing was giving states a fair amount of flexibility. We had a choice of up to 10 plans that existed that we could choose from as a state, like other states. We had the three largest state employee plans, the three largest federal employee plans, the three largest small group plans, and the largest HMO. And so those were our choices. And the ACA mandated that there be 10 general categories of coverage for EHB: ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorders, prescription drugs, rehabilitative and habilitative services and devices, lab services, preventative and wellness services, and chronic disease management, as well as pediatric services, including oral and vision care for pediatrics. So, as I said, Donna's going to talk more about our selection process, but after that process, we did end up choosing for 2014, the Oxford Direct Plan. It's the small group EPO, the largest small group EPO in the state. And then in 2017, we were able to choose again, and we again chose the largest small group plan. It was the Oxford Health Plan EPO for 2017 again. So what I'm going to focus on is under the ACA, how can a state require a QHP, a qualified health plan? It's a plan inside the exchange to offer benefits in addition to the benchmark that the state has selected. So pursuant to federal regulations, state benefits enacted on or before December 31st, 2011 are basically grandfathered in. Those are not considered new benefits, but any benefit added after January 1st, 2012 is considered to be a new benefit. And under the federal law, if a state enacts an additional benefit mandate, it has to defray the cost of those benefits specific to the care, treatment, and services that a state requires a plan to offer to its enrollees. So examples of care, treatment, and services would be if you'd add a benefit, like here, if we'd add a benefit for child locator devices, private duty nursing, acupuncture, hospice care, hearing aids, or vision or dental benefits. Those are all examples of care, treatment, service that don't exist in the current benchmark plan, that if we were to add them, there would be a state cost involved in it. And I'll talk about the state cost in a minute and how we calculate that, because I know, Chairman Cahill, that's a big concern of yours. But what the rule does not apply to are mandates that require access to, for example, types of providers, or mandates regarding delivery methods. So, for example, telehealth, when we're just talking about the mode of delivery of those services, but not the services themselves, or mandates regarding cost sharing or reimbursement. All of those are not considered new benefits for purposes of the ACA requirement that the state defray the cost. Similarly, the federal rule doesn't require the state to defray costs for dependent mandates, which could require an insurer to cover or define or cover dependents in a specific manner, like newborn coverage, adopted children, domestic partners, disabled children. All of those kinds of things are also not, the state would not be required to defray the costs for those. So when we're talking about defraying the cost, what does that mean? The cost to be defrayed is the additional premiums that would be associated with the additional benefits. And in defraying the costs of the additional benefits, the state has to make the payments, so this is state dollars, has to make the payments either directly to the enrollee or to the issuer. And it applies to both individual and small group QHPs, qualified health plans. Again, that's plans sold inside the health exchange in New York. It's the New York State of Health marketplace. So how do we calculate those additional costs? So the federal regulations require that the cost of state-required benefits be calculated by each QHP issuer. So each insurer it calculates that cost. And the calculation must be based on an analysis that's, number one, performed in accordance with generally accepted actuarial principles and methodology. Number two, conducted by a member of the American Academy of Actuaries. And number three, it has to be reported to the state. Not approved, but reported to the state. So HHS has stated in its commentary to the regulations that calculation of the cost of state-required benefits can be based on either, one, the statewide average cost of the additional benefits, or number two, each issuer's actual costs. The state can elect which method to use, and as of now, New York has not elected a particular calculation method. In the past, the Department of Financial Services has estimated potential cost of proposed state-required benefits by looking at a number of different available sources of information. And some of those include the Millman Health Cost Guidelines, which is kind of one of the main industry standards for estimating claims and costs and utilization patterns for various benefits. In addition, publications and journals from different medical societies. We look at publications from health foundations, for example, like Robert Wood Johnson Foundation, or Kaiser Foundation is another one. the cost impact generated by similar mandated benefits in other states in prior years. We would look at that. We would look at government sources, government sources like the National Institutes of Health or Center for Disease Control. We'd look at analysis sometimes provided by advocates or proponents of the different mandates. We'd look, one of the main sources we'd use, obviously, is the Society of Actuaries, national organization, very well respected. We'd look at inquiries with actuaries from selected insurers to see what their actuaries are calculating, and we'd look at other sources that might come up specifically. So real wide range of sources that our actuaries would look to kind of try and come up with cost estimates that we've done in the past. And the last point I wanted to make was just to update you on some recent federal regulations. On March 8th, the final HHS, Department of Health and Human Services, Notice of Benefit and Payment Parameters came out, and it had a number of the following clarifications. So one clarification is that they made it clear that the state, rather than the state exchange, would identify the additional state-based required benefits, if any, that were required in addition to EHB. The second, and this is a really important point, is that the guidance from HHS, the final rule from HHS, made it clear that if a benefit was included in the essential health benefits package, but not currently in state-mandated law, if the state decided to then mandate it, there would be an additional cost for that, even though it was already included in the benchmark plan. So the third thing that that HHS final rule talked about was they addressed states that tried to address in enacting mandated benefits outside of the exchange only, so you wouldn't incur the cost. And they basically noted that was not an acceptable strategy, because QHP and sold inside the exchange has to be sold outside the exchange under the federal guaranteed availability rules, and so would be subject to the other, the outside the marketplace rules. And the commentary also cautioned states that imposing different benefit mandates on the plan's status as a QHP, or because it was sold through the exchange, could violate a federal law that requires all state standards or requirements to apply uniformly in a given market. So, in other words, you can't just deal with the market outside of the exchange. And then the last piece, and you had mentioned this in your opening comments, Chairman Cahill, that they talked about habilitative services and the definition of habilitative services, and made it clear that states are not required to defray the cost of mandates defined as habilitative services as they fall within the definition, and as long as they fall within the definition of essential health benefits, and that states have the flexibility to define habilitative services. However, they note that the state has to use a reasonable interpretation as to what services are habilitative. And the commentary also confirmed that the state has the ability to modify its definition of habilitative services in future years as medical evidence and treatments evolve, and still not be required to defray the costs. So right now in New York, we don't have a statutory definition of habilitative services, but we have defined it in our model contract language. As you may know, we work closely with stakeholders, insurers, providers, consumer groups to come up with a model language that's, a model contract language that's used for all individual and small group, and increasingly for large group coverage as well. And the definition of habilitative services, it's in the written testimony that we provide, but I'll read it briefly. It states that healthcare services that help a person keep, learn, or improve skills and functioning for daily living are habilitative services. Habilitative services include management of limitations and disabilities, including services or programs that help maintain or prevent deterioration in physical, cognitive, or behavioral function. These services consist of physical therapy, occupational therapy, and speech therapy. So New York could modify the definition and would not be required to defray the costs of benefits that fall within this definition. So just in conclusion, really appreciate the opportunity to provide input on this important issue. As noted, federal law and regulations are pretty clear that in requiring states to defray the cost of benefits that are in addition to EHB, states have to defray the cost of any state mandate. The cost to be defrayed is the additional premiums associated with the additional benefits, and defraying the cost of the additional benefits, the state has to make payments to either the enrollee or the insurer for both individual and small group QHPs. And so, as always, we need to carefully consider the benefits that are currently required to be covered under EHB, the benefits that would be in the new mandates, and any costs that were associated with requiring the new mandates. And I just wanted to thank you, Chairperson Cahill, and I see Chairperson Gottfried has come in, as well as Assemblymember McDonald, and Assemblymember Barkley. Thank you all. Really appreciate the opportunity.
Thank you, Mr. Oshner. Your testimony has already been enlightening. Ms. Frescador, if you'll just indulge me for a moment, we've been joined by Assemblyman John McDonald, who represents a significant part of the Capital District, and also by Chairman Dick Gottfried from the Health Committee. Well, I'll ask John to forbear and wait and just wait till he's asking questions and making comments later. Would like to give Dick an opportunity if he wishes to make a brief opening statement.
Just to say that I probably would have been here at the start of your testimony if Amtrak had run a little quicker this morning.
I covered for you, Dick.
Thank you.
So with that, we'd like to move on to the Executive Director of the New York State of Health, Donna Frescador. Welcome, Ms. Frescador, and thank you for coming.
Thank you. Thank you. Good morning, Chairman Cahill. Good morning, Chairman Gottfried, and Assemblymember McDonald and Barclay.
Can you move a little closer to the mic as well?
Certainly can.
The acoustics in this room were designed in the 1960s.
On behalf of New York State of Health, our marketplace, and the Department of Health, thank you for inviting us to participate today. Troy, I think, has done a terrific job, both in his submitted testimony and also in just explaining the requirements of the Affordable Care Act as respects the essential health benefits that are offered to both individuals and small groups, both on our state marketplace and off our marketplace. I thought this morning that I could perhaps provide some additional details about how we selected the essential health benefits here in New York, and also talk a little bit about how that decision is reflected in the insurance options that are offered on our marketplace. So first, a little bit more detail about the selection of our essential health benefits. I think we have all, along with stakeholders, acknowledged since the beginning of our planning process for the marketplace what a very important decision this is. It impacts individual consumers, small businesses who purchase on the marketplace, who purchase directly. From the standpoint of the services that will be covered, certainly affects our providers here in New York. It affects our insurers in New York, and it affects the cost of coverage. And so I think of all the decisions I might submit that were made along the way, this is certainly among the most important of them. And so in recognition of the importance of the decision, we began a public stakeholder process first in 2012 as we were planning for our marketplace in partnership with the Department of Financial Services, which informed the selection of the essential health benefits for benefit years 2014 through 2016. And that, in fact, was based on plans as of 2012. We did the exercise again under federal rules in 2015. for benefit year 2017, so this upcoming January, based on the benchmark plan's benefits in place as of 2014. So the options stayed the same from one analysis to another. Troy mentioned them, the three largest federal employee health benefits under their program, the three largest state employee plans, which are the Empire Plan, CDPHP here locally, and Independent Health in the western part of the state. The three largest products offered in the state's small group market, which Troy discussed, and the largest commercial group HMO in the state, so the non-Medicaid HMO, which is a product that is underwritten by HIP and in New York City. Troy mentioned also that regardless of which EHB benchmark we select, the benchmark must cover certain services. Those are included in the testimony, and I won't repeat them here today, but I think with the exception of habilitative services, which was new to us in 2014, and the inclusion of pediatric dental and vision, those services were largely already covered here in New York. We engaged Milliman actuaries to conduct a New York State specific analysis of each of our 10 benchmark options. We asked them to focus on the differences between those options, both in terms of the categories of service that are covered by those benchmarks and any quantity or service limits, remembering that under the ACA, while dollar limits are prohibited, there can still be limits on the number of services or number of visits. Important, I think, to note what the essential health benefit decision does not do. Troy mentioned some of that. I'll add that it does not address cost sharing, so it does not dictate deductibles or coinsurance or copayments. Those come along in another part of the determination of the benefits as part of the actuarial values of the products offered on the marketplace. It also does not address provider network configurations or how services are delivered. All of those are certainly important to consumers and all stakeholders and have an impact in premium, just separate and apart from our EHB analysis and decision. So Milliman completed for us their most recent analysis in July of 2015. It was published in a report. We've provided the website for that report in our written testimony. And we conducted a webinar in June of 2015 with stakeholders to brief them on the findings of Milliman's report. Just briefly.
Could you try pulling your microphone closer?
Yes. Better? Is that better? Worse?
We'll see.
Okay. All right. So what?
Acoustics in this room were developed in the 1960s. They were by somebody who was an amateur in the 1960s.
Okay. What Milliman's analysis generally found is that while there were 10 different benchmark selections, they were more similar than dissimilar, the way the federal rules are structured. And in fact, in 45 categories of service, all 10 benchmark plans were actually the same. So the analysis really began to focus on how they were different. After Milliman adjusted for the requirements to cover the 10 federally required benefits in the law that Troy discussed, and looked at state mandates here in New York that had been enacted before December 31st, 2011, and allowable under the EHB determination, there were 9 categories of service where we really focused that were in one of the benchmark options, but not all of them. And they're detailed in the report as well. There were also in 8 different categories of service, slightly different benefit limits. That is where the number of services that were covered varied from one benchmark plan to another. After considering all of the options and vetting those different decisions and receiving and taking into consideration stakeholder feedback, New York selected the largest in terms of enrollment, small group product as the 2017 EHB benchmark, finding that as we had for 2014 through 2016, that it resulted in the most comprehensive benefits available to individuals and small businesses at the lowest increase in premium cost. So it had the least premium impact cost, yet the most comprehensive benefits. There were other options that would have lowered costs more, but certain categories of benefits that were not included in those options because they weren't in the federal law and because they weren't state mandates. So we felt that like this decision the prior decision that this option really struck the balance of comprehensiveness and affordability. Our decision is consistent with national trends. All but 4 states, in fact, according to the selections published by CMS, have opted for the small group plan as their EHB benchmark for 2017. 3 of those states, Arizona, Colorado, and Utah, picked their state employee plan. New Mexico selected their largest non-Medicaid HMO. So from the marketplace perspective, there's a couple of points that I just wanted to add today and hope that they're helpful to the discussion. First, and Troy mentioned this, that in practice, the essential health benefits serve as a floor for the services that are covered for people who are purchasing on the marketplace. Insurers must offer that floor of benefits to both individual consumers and small businesses. Importantly, it also serves as the basis for the calculation of federal tax credits for individuals. That is, when we calculate the tax credit that an individual will receive when they purchase on the marketplace, we can only include the value of essential health benefits. But that said, insurers can and do offer benefits in addition to the EHB benefits on our marketplace. Several of them offer both upstate and downstate access to services not in the benchmark, such as adult dental and vision care, acupuncture, other services, some variation in the service limits as well. The cost of those services, however, are included in the premium that the consumer would pay for that particular product. They are not funded by the state because they're not mandated, or they can't be included in the case of adult dental and vision under the federal rules. We think that's an important point, and as we look at how consumers are selecting their health plans, we do in fact see that some percentage of consumers are selecting plans that offer those optional benefits because they're important to them. The second point, and it's something that I think is something we're looking at certainly more recently, starting in January 1st, 2016, as you know, and as authorized by New York State Social Services Law, New York State of Health implemented the Basic Health Program. As you know, that's a state option under federal law for persons with incomes at or below 200% of federal poverty level who are under 65, not eligible for Medicaid or Child Health Plus. Under the Basic Health Program, as you know, New York receives 95% of the federal tax credits that the individual would have received had they enrolled in a qualified health plan through our marketplace. That revenue is placed in trust and available to New York to administer benefits to people who have enrolled in the Basic Health Program. We expect and we believe we'll achieve enrollment of over 470,000 New Yorkers in that program over the year. Terrific program, in fact, for lower income New Yorkers. Interestingly, there is a connection between the Basic Health Program and our essential health benefit decision. In fact, under federal rules, we must select one of the EHB benchmark options to be the benchmark benefits for our Basic Health Program. What we believe would need to be explored is that to the extent new insurance mandates expand the services that are covered under our state's essential health benefits, those services must also be included in the Basic Health Plan. I think this is a relatively new consideration, given the newness of the BHP here in the state, that we would need to consider, and that any increases in the cost of the Basic Health Plan would be borne by the trust and may increase the cost of the state unless they're offset by member cost sharing increases or premium contributions, which, as you know, are $20 or less per month. We appreciate the opportunity very much to provide information. We are committed to working with our partners at the Department of Financial Services and stakeholders who have been so very supportive in the implementation and operation of our state's marketplace to ensure that New Yorkers continue to have access to affordable coverage, and coverage that's comprehensive as well. So I hope this information has been helpful. We're certainly available to answer your questions either now or in follow-up.